Welcome to the Learn Pediatrics examination of the abdomen.
How old are you?
Here, we will review a general approach to this examination. Note that if a specific pathology is suspected, a more detailed exam may be indicated. Clues about a child's gastrointestinal health should be sought not just from the abdomen, but also from his or her general well-being and from a global overview of the other systems. As with all physical exams, be sure to plot the child's growth parameters on appropriate growth charts. Recording a series of measurements is particularly useful in order to establish a trend or to establish whether a concerning measurement reflects an acute or chronic change. General inspection. Start with a general overview of the child's appearance. Identify the child that looks acutely unwell, such that immediate action can be taken. Ensure vital signs are stable. Note the child's level of mental status. Take note of the child's posture. The child that is writhing and unable to lie still is likely to suffer from colicky pain, while the child that minimizes movement may have appendicitis or peritonitis. Note any changes in color. A patient with jaundice and sclerolicterus is likely suffering from liver disease, while a pale patient may have anemia. Furthermore, take note of the patient's nutritional status. A cachectic appearance or signs of muscle wasting may be present in different chronic conditions, including malabsorption or protein wasting. Peripheral edema may suggest hypoalbuminemia. Then focus on the skin. There are some gastrointestinal conditions that manifest skin lesions as part of the extraintestinal symptoms of the disease, such as dermatitis herpetiformis in celiac disease or erythema nodosum in inflammatory bowel disease. If inflammatory bowel disease is suspected, evidence of other extraintestinal manifestations should be sought, such as uveitis, aphthous ulcers, clubbing, and arthritis. Stigmata of liver disease are less common in the younger child, but may be seen in the older child with chronic liver disease. These include whitening of the nails, muscle wasting, palmar erythema, spider angiomas, asterixis, jaundice, caput medusa, and gynecomastia.
Thank you.
Abdominal inspection. Proper positioning and lighting is important to properly visualize the child's abdomen for contour, peripheral vascular irregularities, and skin markings. The patient should be supine with his or her hips slightly flexed. This relaxes the abdominal muscles, giving better access to deeper structures. Always examine the patient from the right side and ensure the patient is appropriately draped and comfortable. Look for abdominal distension, which may indicate abnormal gas-filled bowel loops, fecal retention, a mass lesion, ascites, or a ruptured viscus. On the other hand, a scaphoid abdomen can be seen in a patient with upper GI obstruction or as a result of starvation. Peristaltic waves may be seen on occasion, but are especially prominent in pyloric stenosis. Look for abdominal scars suggesting previous surgery, which puts the patient at risk for obstruction, secondary to adhesions or secondary to stenosis, in the case of a previous bowel resection and anastomosis. Look for vascular markings. In children, hemangiomas are common and not a concern. Prominent veins, such as caput medusa, however, can be seen in chronic liver or renal failure. Look for abdominal wall protrusions. Umbilical hernias frequently are present in the infant, toddler, and younger child. Most umbilical hernias are uncomplicated, require no surgery, and resolve spontaneously. Diastasis recti and small epigastric hernias, if not readily visible, can be elicited by having the patient raise his or her head off the examining table while lying supine, or by having the child tense the abdominal muscles. These hernias do not require surgical correction. Auscultation. Auscultate prior to palpation of the abdomen to avoid creating abnormal gas patterns or obliterating normal intestinal sounds. Abdominal sounds are most useful in the child with significant abdominal discomfort. Active bowel sounds, or borborygmi, may be heard in patients with gastroenteritis or at an area of bowel stenosis. Bowel sounds are decreased or absent in patients with appendicitis, ileus, or intestinal obstruction. Also listen for bruits, which may be present in stenosis of the aorta or other large vessels such as the iliac, femoral, or renal arteries. Percussion. Percussion helps detect mass lesions and assess organ size. In the acutely ill child, percussion is used to gently identify tenderness prior to palpation. Percuss to determine if hepatomegaly is present, starting from the right lower quadrant, then ascending to the right upper quadrant. The transition between a tympanic and dull percussion tone marks the lower border of the liver. Then start over the right lower lung field, percussing downwards to find the upper liver border. A normal liver span in the mid-clavicular line for a child depends on gender and on age. At 1 week of age, the liver span should be less than 5 centimeters, while at 12 years of age, up to 8 centimeters in boys and 7 centimeters in girls. Although percussion may be employed to determine if splenomegaly is present, this test is not very sensitive. Nonetheless, this would be done using Castell's method, where one percusses in the lowest intercostal space in the anterior axillary line. If percussion in this area reveals transition from a tympanic sound to dullness during inspiration, Castell's sign is said to be positive for splenomegaly. Alternatively, one can percuss within Traub's space. This is the triangular area between the left sixth rib, left mid-axillary line, and left costal margin. Dullness to percussion in this area may indicate splenomegaly, though this can be falsely positive after a meal. Percussion can also be used to determine the presence of ascites using 2 different methods. In the first, a test for shifting dullness is performed, starting with the patient supine. Percuss from the flank towards the umbilicus in a plane perpendicular to the bed. At first, dullness will be noted, but as one approaches the umbilicus, the air-filled loops of intestine pushed centrally by peritoneal fluid will sound tympanic. Next, ask the patient to roll on their side. Repeat the maneuver. If ascites is present, the fluid will redistribute into dependent areas, and the line between tympany and dullness will be shifted accordingly. The second test for ascites tests for the presence of a fluid wave. Ask an assistant to place a hand vertically over the center of the abdomen with the patient supine. Then tap one flank with the tips of the fingers of one hand while feeling for a fluid wave over the contralateral flank. Palpation. Palpation is used to detect masses, organomegaly, and abdominal tenderness. The often ticklish younger child may require a calm, reassuring touch and no initial hand movement by the examiner. Palpation can be aided by asking the child to take a deep breath and then exhale slowly while the examiner applies firm, steady pressure to the abdomen. The softer and less tense the abdominal musculature, the more easily organs and masses can be felt. For the obese child, a 2-hand technique with the fingers of one hand applying pressure on top of the fingers of the other hand may be required. Start with superficial palpation, progressing to deeper palpation. When peritonitis is suspected, rebound tenderness may be elicited by pressing firmly and slowly on the abdomen and then quickly releasing pressure. Subsequent wincing, apprehension, or other signs of pain upon withdrawal of pressure suggests peritoneal irritation. Next, palpate for organomegaly. To feel the liver, place the fingers of the right hand over the lower quadrant in a somewhat oblique position. Palpation should progress in a superior direction until the lower edge of the liver is detected. It's important to start low enough, as an enlarged liver may be missed if initial placement was above the liver edge. In the newborn, the liver edge may be felt about 2 centimeters below the costal margin, while in older children, the normal location of the liver edge is flush with or behind the inferior costal margin. Also try to assess whether the liver edge is soft or hard, smooth or boggy. A similar maneuver is used to determine the size of the spleen. In children, it's important to start palpation for splenomegaly in the right lower quadrant as the spleen enlarges across the midline. Some clinicians use the scratch test to determine the inferior margins of the liver and/or spleen by listening with a stethoscope while gently scratching the skin surface with a fingernail or blunt instrument. Placing the stethoscope over the right lower chest at about the level of the 7th rib, listen for a change in sound quality as your finger ascends over the liver border. The same can be done over the left for the spleen. The kidneys are palpated in a two-handed technique. Palpate deep anteriorly with your one hand and in the costophrenic angle with your other hand. An enlarged kidney will be palpable by the anterior hand. Renal tenderness is determined easily in a cooperative child through percussion over the costovertebral angles. With the child sitting up, firmly strike over the back with the ulnar surface of a closed fist. This will elicit marked discomfort in the patient with pyelonephritis.
No pain? No.
Several positive physical findings may help make the diagnosis if appendicitis is suspected. Patients typically report periumbilical pain, which travels to a point 1/3 of the distance from the anterior superior iliac spine to the umbilicus in the right lower quadrant. This point, known as McBurney's point, roughly corresponds to the location of the base of the appendix where it attaches to the cecum. Light palpation over this point may elicit tenderness and guarding. Deeper palpation and quick release of pressure may create rebound tenderness. Tenderness over the right lower quadrant while palpating the contralateral side is often found, Rovsing's sign. In advanced cases of appendicitis, significant abdominal muscular rigidity can develop, making palpation difficult. Depending on the position of the inflamed appendix, some special tests can be elicited to further support the diagnosis of appendicitis. The psoas sign elicits pain on right hip flexion tested against resistance or on passive extension of the hip, present when the inflamed appendix is located in the retroperitoneum and is irritating the psoas muscle. The obturator sign involves pain on internal rotation at the hip, a maneuver which stretches the obturator muscle, which may be irritated when the appendix is located inferiorly. Also part of the exam of the gastrointestinal system is a good assessment of the groin for lymphadenopathy, inguinal hernias, or femoral hernias. In boys with abdominal pain, the scrotum should also be examined for possible testicular torsion or incarcerated inguinal hernia. Both these diagnoses are medical emergencies and should not be missed. For girls, possible ovarian torsion must be considered. In sexually active girls presenting with abdominal pain, a gynecologic exam may also be indicated. Inspection of the anus and rectum is relatively standard for all age groups. In the newborn infant, look for an imperforate or anteriorly placed anus. This anatomical abnormality is relatively rare, but should not be missed. In the older child, infantile perianal pyramidal protrusions, IPPP, also known as perianal skin tags or skin folds, may be seen, more commonly in girls, and is associated with constipation or lichen planus. The lesion is typically located in the midline, just anterior to the anus. Perianal fissures, also associated with passage of hard stools, are seen in all age groups. In the older child with suspected inflammatory bowel disease, the presence of perianal abscesses or fistulas should be sought. Hemorrhoids are found primarily in older patients. In patients suspected of having been sexually abused, careful examination of the perianal area for bruises, tears, and lacerations is important. Digital rectal examinations are not performed routinely as part of the regular physical examination of children. This may, however, be indicated for the child with a lower abdominal mass and/or history of infrequent passage of stools or constipation. When digital examination becomes necessary, the examiner should remain sensitive to the potential embarrassment and discomfort for the patient. One also needs to explain why a rectal exam is necessary and the details of what the exam entails before proceeding. The examination is performed best with the patient lying on his or her left side and legs flexed at the hips and knees. Gloves and an appropriate lubricant should be used. A smooth-walled rectal vault with soft stool in the rectal ampulla is the normal finding. A palpable abnormal mass or blood-tinged stool on a gloved finger requires more extensive investigation. Assessment of anal tone is important where Hirschsprung's disease is suspected and also in trauma victims with possible spinal cord injury.
Good, Michaela, so I'm done with the exam.
Conclusion. This concludes the abdominal examination in the pediatric patient. Remember that, like with all physical exams, becoming competent at performing a complete yet efficient abdominal exam takes time. Depending on the age of the child, different approaches to the exam may be required, and different physical findings may be expected. Proficiency at changing your approach to the exam to better suit the clinical situation at hand is a skill that will develop over time.